Good morning, everybody. My name is Shannon Echeverry. I am the director of the Turner Senior Wellness Program. And today we are doing our presentation on sleep. So hopefully everybody's awake this morning, ready to go. We have Kailash Deer, who is a geriatrics fellow at the East Ann Arbor Geriatrics Clinic, who's going to be presenting today. So a few groundkeeping things before we get started. So today, a Q&A is going to be done after the presentation. So please note it should be at the bottom of your screen. If you're on a computer, there is a Q&A box. So you can submit your questions there. And at the end, we'll try to get to as many questions as we can. We also have an option to show closed captions. So there's a little button that says CC at the bottom as well. And you can also play around with your view settings if you want to see the presentation or our speaker or both. So that is under the view option, speaker gallery. And also because this is a webinar, you can see us, but we cannot see you. So as a reminder, put your questions in the Q&A, and I hope that you enjoy this presentation. And also, this is going to be available on the Turner Senior Wellness Program website within a week or two. So please help share this information with your friends and family. We can send out this link once it is available. So thank you all very much. I am going to pass it over to Kailash. Thank you.
Hi, everyone. I'm just going to share my screen here and we'll get started. Give me one moment. Go. Share. All right. Can we see everything okay?
Looks great.
All right. So as Shannon was saying, my name is Kailash. I'm one of the geriatric medicine fellows at the University of Michigan. I think today we're covering an important topic on sleep, and specifically on the idea of how we can improve sleep as we age. So a couple of disclaimers to make. I have no conflicts of interest to disclose, financial or otherwise. I'm not an expert in sleep medicine. My background is in family medicine, and I'm currently training to become a geriatrician. The other important point I'd like to make is that this presentation is a broad overview. It's not intended to diagnose and treat conditions. Everyone has their own unique medical history. And so in order to be safe, it's important to talk with your primary care physician about symptoms of possible sleep disturbance you might have and potential management, because they are most familiar with your medical history. So this is the outline of our presentation today. First, I'll speak generally about sleep disturbance in older age, epidemiology, risk factors, outcomes of this. And then I'll briefly talk about how, as we get older, there's age-related changes in our sleep architecture. But then the bulk of the presentation will be on sleep disorders, specifically insomnia. And then I'll cover 4 additional sleep disorders that are the most commonly seen as we age. So sleep disturbance in older age, it's very common. It's estimated that approximately half of those 65 years and older report some form of sleep disturbance. And also with that, approximately 5% of older adults are estimated to use sedative hypnotics like benzodiazepines on a daily basis. Sleep disturbance is more commonly seen in females versus males, more commonly seen in African American population, those with depression and chronic illness. And late life disturbance is typically a chronic problem, lasting on a scale of years, if not indefinitely. So the question we should ask is, why are older individuals more impacted? First, there's sleep architecture changes seen as we get older. I'll spend more time in the coming slides going over this. Um, other, re other reasons why older individuals might be more impacted is there's just a higher burden of medical disease, higher burden of psychiatric and neurocognitive disease, untreated or undertreated pain, medication side effects, just by the fact that as we get older, we accrue um, more medications. And then stressors too, so things like social isolation, bereavement, caregiving responsibilities, all of these factors likely play a role in why we have sleep disturbance. So, and we care a lot about this is because poor sleep is associated with many poor outcomes related to our health. So there's an increase in fall risk, higher rates of depression, poor control of medical conditions we already have, greater morbidity from acute medical illness, so it means we're sicker, essentially, increased risk of cognitive decline, increase all-cause mortality, which essentially means our chances of death go up, death from any cause. And then there's an association with worse health-related quality of life, increased medication use, and greater healthcare utilization. So it's something that we should not take lightly. And now we'll switch gears slightly. Like I said, we'll talk about sleep architecture changes, specifically those changes that are seen as we age. But before I do that, I just like to spend this slide talking about normal sleep architecture. So sleep is classified into different stages based on our brainwave patterns, eye movements, and muscle tone. There's two phases of sleep, non-rapid eye movement sleep and rapid eye movement sleep. Non-REM has 3 stages. The first 2 are pretty light sleep, N1 being the very, very light drowsy sleep, N2 slightly deeper sleep, but there's slowing of brain and heart activity. N3 is the deepest sleep, and it has it plays a special role in the restorative reparative function of our sleep. So sleep is important for balancing hormone levels, controlling our metabolism, lowering blood pressure, boosting immune defense, repairing DNA, and recovery from psychological trauma. So N3 sleep, as you can see, is important. And then REM sleep, rapid eye movement sleep, is our brain activity is similar to the awake state. We dream in this sleep, and there should be a complete loss of muscle tone. And then as we sleep, we go through these phases. In the first half of sleep, we spend more time in deep sleep than REM sleep. In the second half of sleep, we spend more time in REM sleep than deep sleep. Typically, we should go through 4 to 6 cycles of these different phases per night, and we typically spend 90 minutes in each cycle. So as you can see here, studies have shown that there's a typical pattern that's seen as we age, where the architecture that is normally seen early in life changes. So overall, we spend overall, we spend more time in lighter sleep, so N1, N2, less time in deep sleep, N3, less time in REM sleep. We typically go to bed earlier and wake up earlier. There's overall a shorter nighttime sleep duration. There's more sleep fragmentation, so waking up intermittently throughout the night. More time we spend awake after we've started to sleep, and then consequently more frequent napping during the day. And then something that you may see come up again later on in this presentation is something called sleep efficiency, which is the percent of time we spend in bed sleeping versus the total time we spend in bed. And that goes down as we age. So now, again, switching to specific sleep disorders, like I said, we'll spend the majority of the time talking about insomnia, and then later on, moving to these 4 additional sleep disorders that kind of correlate to aging. But before I, delve right into all the details, I just want to take a moment to say that the term insomnia is pretty interesting. In different contexts, it can, um, you know, mean a symptom, but in other contexts, it implies a specific disorder. The American Academy of Sleep Medicine classifies insomnia as one of 8 major categories of sleep disorders. And then within insomnia as the umbrella term, there's subclassifications, 12, I believe. So this could include acute insomnia, idiopathic insomnia, insomnia due to mental disorder, insomnia due to medical conditions. And then, but the biggest point I'm trying to make is that with regard to the other sleep disorders, insomnia complaints can be seen in, sleep disordered breathing and circadian rhythm disorder, or there can be overlap. So these things aren't easily separated out. All right. So insomnia is defined by an inability to sleep, stay asleep, or waking up earlier than desired with an impact on quality of life. Impact on quality of life is very important to make insomnia disorder. It's very common, almost 30 to 48% in those 65 years and older. Again, more common in women than men, more common in individuals with low socioeconomic status, African American, and those with medical comorbidities. And an important point to make is that it's often seen with those with psychiatric conditions, so specifically depression and anxiety. Medical conditions that most commonly have insomnia as a comorbid disorder include hypertension, heart disease, lung disease, acid reflux, which is GERD, stroke, neurodegenerative disorders like Alzheimer's. And then, it's not only just having the comorbid medical disease that makes us more disposed to having insomnia, but it's often the symptoms that that accompany these conditions. So like pain, shortness of breath, that makes it difficult for us to sleep. And then also too, insomnia, we look for medications that could be making it difficult for us to sleep. So taking medications that can make us more awake if they're taken at bedtime. So for example, thyroid medications like levothyroxine, bronchodilators, and then a whole host of psychiatric medications. And then also too, if we take sedating medications during the day, that can cause us to, nap and then there can be less of a sleep drive when we would like to sleep. So these include certain antihypertensives, antihistamines, and also antidepressants. All right. So typically when we evaluate someone with insomnia, it's common for a practitioner to ask for a sleep diary for about 1 to 2 weeks duration. Typically tells us, when individuals are falling asleep, how often they're waking up, when they wake up, if they're napping during the day. It's also important to know any caffeine, alcohol, or medication use, because like I said, this can all affect how we sleep and our quality of sleep. And then we also look for comorbid sleep conditions, so like obstructive sleep apnea or restless leg syndrome that could be going along with this insomnia. The biggest point I'd like to make, the biggest takeaway from this lecture is the first line treatment for insomnia is cognitive behavioral therapy. It's not pharmacologic. So we typically try to reserve medications for transient sleep disturbance, like if you're jet lagged or you're going through some sort of trauma or loss of a loved one, or if you have persistent chronic insomnia despite going through intensive behavioral intervention. Medications you might have heard of that are used for sleep include benzodiazepines, so temazepam, zolpidem. Then there's Ramelteon, doxepin, mirtazapine, trazodone, suvorexant. This is definitely not all the medications that have been used for sleep, but some of the more common ones. And like I said, there's a reason why we recommend behavioral therapy as first line versus medications, because a majority of these medications, if not all of them, have significant side effects. So a lot of them are known to increase our fall risk. There's some daytime carryover, which means you take it at night. It has an effect of sedating, but then you can continue to feel sedated during the day, which is not good because, again, it can increase your fall risk, make it, higher incidence of car accidents. It can also, certain medications can increase your risk of headache, dizziness. So they're not ideal. So again, kind of spending a little more time here on cognitive behavioral therapy for insomnia, so CBTI. Again, it's first line. There have been studies that shown that it improves sleep efficiency. So the amount of time you're spending in bed sleeping there's a higher percentage versus the amount of time total you're spending in bed. There's evidence for CBTI, decreasing nighttime wakefulness. An individual has greater satisfaction with sleep, more sustained improvements in sleep, and fewer side effects compared to pharmacological therapy. The one downside to this is that, as you probably are aware, there's limited access to practitioners trained in this type of therapy. But there's been movement to overcome this in that, trying to use the internet, telehealth, trying to use non-specialist providers just to make access more available. CBTI, there's different components to CBTI. So sleep hygiene, stimulus control, sleep restriction, and cognitive therapy, which we'll talk about in the coming slides. So sleep hygiene, I'm sure if you've talked about insomnia with your provider, they've probably mentioned this. It's a pretty broad term, and it's just essentially a general practice to maintain a healthy sleep-wake routine. So components of good sleep hygiene include, first of all, checking effects of your chronic medications on sleep and wakefulness and making appropriate adjustments if possible. Avoiding alcohol, caffeine, cigarettes after lunch, because all of these can be very stimulating. Limit liquids in the evening so that you're not feeling like you need to wake up and go to the bathroom at night. It's important to keep a regular bedtime and wake time schedule, so trying to go to bed around the same time every night and wake up at the same time every day. Limiting naps, specifically one nap to no more than one nap a day, no longer than 30 minutes, because anything more in terms of frequency or duration can impact our sleep at night. Spending time outdoors without sunglasses, particularly in the late afternoon or early evening, can help with sleep as well. And I know that's probably hard to do in Michigan where it's gray most of the time. And then exercise, there's evidence that exercise can help with sleep hygiene, but it's important to note that this should be avoided right before bedtime, because this can actually cause the opposite effect and keep us up. So stimulus control is another component of CBTI. Yeah, stimulus control is another component of CBTI. Really, it's defined by breaking the negative associations one has with the sleep environment, which have resulted from maladaptive behaviors. That's how we define it. The idea is that if you condition the brain to recognize the bedroom as a place to sleep, the room itself will kind of serve as a cue that helps us fall asleep. So oftentimes you might hear the term sleep sanctuary. So this can include, how we set up the room. So curtains that block light, using dim light only, blue light filters, a cool temperature, sleep promoting colors, which, when I looked into this more are white, blue, and green, and then using fragrances such as lavender. And then the, three most common activities that have the opposite effect that would keep us up at night and block sleep, that I know a lot of us might do is watch TV, working on a laptop, and talking or browsing on the phone while in bed. So that's kind of to introduce stimulus control and setting up the bedroom, but specifically, when we talk about stimulus control, we talk about these main components. So really avoiding any other activities in the bed aside from sleep or sex, only going to bed when tired or sleepy. If you're unable to fall asleep within 20 minutes, you get out of bed and the bedroom and do something quiet and relaxing. This often includes avoiding any sort of screen time because, again, that can be stimulating. The idea is that you only return to bed when you're sleepy. If you're unable to fall asleep within 20 minutes, you get out of bed again, and then you continue the cycle until you can fall asleep within a few minutes. And then an important thing is you try to get up at the same time each morning, even only after a few hours of sleep, and you should avoid naps. So another component of CBTI is something called sleep restriction. So the idea behind this component of therapy, is that you restrict your duration of sleep to the time that you've actually been sleeping based on your sleep diary. And this leads to sleep deprivation, which therefore increases sleep drive, and ultimately makes it easier for us to fall asleep sooner and have more good quality sleep. So the way this works is you calculate the average amount of time of sleep per night based on the sleep diary. You only are allowed to stay in bed for this amount of time plus 15 minutes. You get up at the same time each day. You avoid daytime napping again. And then when sleep efficiency has reached about 80 to 85%, so again, the time that you're actually asleep versus the time that you're in bed is around 80, 85%, you're allowed to go to bed about 15 minutes earlier. And then again, you repeat this procedure until you can sleep for about 8 hours or a period that you feel gives you a good night's sleep. So this is all these interventions are pretty extreme and probably a change from your routine. So again, I just want to point out that it's important that you work with someone who's trained in this sort of therapy before you undertake this on your own in order to do this as safely as possible. Lastly, a fourth component of CBTI is cognitive therapy. So you work with a therapist, and you address thoughts and dysfunctional beliefs that you have about your sleep. You try to incorporate mindfulness and other relaxation techniques. There may be a place for bright light therapy. So if you have advanced sleep phase disorder, so you go to bed too early and that's, interferes with your daily activities, then you would expose yourself to light in the evening. And if you are having trouble falling asleep, such as in delayed sleep phase, then you expose yourself to bright light therapy in the morning. Bathing before bedtime is also a relaxation technique that can help promote sleep. And then again, moderate exercise program, such as Tai Chi, can help with sleep. I kind of wanted to expand on this a little further. This isn't specifically written in CBTI guidelines, but through a program that I did with integrative medicine, when they talk about sleep promoting behaviors, there can be an integrative approach to how we manage our sleep, insomnia. So certain botanicals, there have been very limited studies that show some evidence that these can be helpful. So these include valerian, ashwagandha, chamomile, kava, California poppy, and passion flower. Again, limited, so it's always a question of risk versus benefit. I would talk to your primary care provider because even though botanicals and supplements can be pretty innocent, they can sometimes interact with medications that were prescribed. Supplements that have shown to be possibly helpful include magnesium, melatonin, and L-theanine. And then specifically more about the type of mindfulness approach that that has been shown to help with insomnia include mindfulness-based therapy for insomnia and mindfulness-based stress reduction therapy. And then again, yoga, not only Tai Chi, but yoga, aerobic and strength exercise. These have shown some benefit. And specifically, they talk about how an AM routine of exercise can be actually possibly more effective than exercising in the afternoon, which I thought was interesting. And then there has been some, again, limited studies that show how acupuncture can help with insomnia. So you're probably wondering, after we spent so much time talking about cognitive behavioral therapy for insomnia, where can I access this? Two websites that I found that could be helpful to, just learn more about insomnia and other sleep disorders, but also find providers in the area and places in the area that could provide this care. Two websites that I'll point you to are the American Board of Sleep Medicine and the Society of Behavioral Sleep Medicine. So now that we've covered insomnia, we'll switch gears and talk more about those 4 sleep disorders that I want to just highlight because they are more common as we age. The first thing I'll talk about is sleep disordered breathing. So these are defined by repetitive events of complete or partial cessation of airflow during sleep. So there's 2 main sleep disordered breathing conditions. One is obstructive sleep apnea, where there's an obstruction in the airway despite our persistent effort to breathe. And then there's central sleep apnea, where it's more central, like the brain doesn't tell us to keep breathing. So there's a cessation of breathing effort. The risk factors for both of these are more common as we age, and therefore these sleep disorders are more common as we age. So for OSA, that includes an increased BMI, decreased muscle tension, changes in airway anatomy, increased airway collapsibility, decreased thyroid function, and decreased lung volume. And then for central sleep apnea, this has been associated with congestive heart failure, atrial fibrillation, chronic kidney disease, chronic pain requiring medications such as opioids. The major symptoms that you might find in these disorders include snoring and daytime sleepiness. And then the really only way to diagnose these disorders are with polysomnography. So you may have already heard of this. It typically involves going to a sleep center and then hooking you up to multiple different leads, and they measure various things such as, brainwave pattern, blood oxygen levels, your heart rate, respiratory rate, eye and leg movements, among other things. So, and then most common management is with positive airway pressure therapy, and that's most commonly a CPAP machine. The next disorder that I'll talk about is actually 2. So restless leg syndrome and then periodic limb movement disorder. So restless leg syndrome, again, we're talking about this because they're more common as we age. So restless leg syndrome, it's defined by an uncomfortable sensation in the lower extremities leading to an urge to move them. PLMS, are periodic limb movement in sleep. You see a cyclic movement of the lower extremities during sleep. It's usually seen in those who have RLS, REM behavior disorder, and narcolepsy, and then it's called a disorder when it's not associated with these conditions. So again, like I said, both conditions increase with age. risk factors for this is iron deficiency and a family history, chronic kidney disease, antihistamines, antidepressants, and then really a risk factor for PLMD is really just family history. RLS can just be diagnosed with, report of symptoms alone, but PLMD requires undergoing a polysomnography. And then management is with iron supplementation and certain medications. So then we'll talk about REM sleep behavior disorder. It's basically defined by recurrent complex movements or vocalizations during sleep characterized by dream enactments. So it's pretty dramatic. And we see this incidence of this disorder increase with age because it's often seen in other conditions that increase with age, specifically certain neurodegenerative conditions such as Parkinson's, multiple system atrophy, and Lewy body dementia. This is also diagnosed with polysomnography, and then management is, limited, but there's some evidence that certain drugs can help, so melatonin, clonazepam, and then very importantly is trying to create a safe environment for the patient and bed partner. So that can mean, sleeping in different beds or moving the mattress to the floor, making sure there's no sharp objects in the room, nothing that, that could fall over onto the patient or the bed partner. And then lastly, I'll talk about circadian rhythm disorder. So essentially, this is a problem where the pattern of sleep is disrupted because there's a misalignment between one's endogenous circadian rhythm and their desired sleep-wake cycle, but has to result in bothersome symptoms and or excessive daytime sleepiness. So, for example, if you go to bed at 7 p.m. and wake up at 5 p.m. and 7 p.m. and wake up at 5 a.m. and this, this is what you do and this doesn't bother you, then it really wouldn't be classified as a disorder. There's three main kinds. There's delayed sleep-wake phase disorder, advanced sleep-wake phase disorder, and irregular sleep-wake phase disorder. So in the delayed form, you typically have trouble falling asleep. So you're awake pretty late at night, longer than you would want, and then you wake up later. Advanced sleep is when you just fall asleep much earlier than you would want, and then you wake up earlier than you would want. And then irregular sleep-wake phase disorder is there's just multiple bouts of sleep within 24 hours. There's no real pattern. This is most commonly seen in nursing homes. So again, the primary way to diagnose these disorders is through a sleep history, figuring out when someone's falling asleep, when they're waking up, if they're waking up during that phase as well. And then management is, again, with light therapy. So if you fall asleep too early, if you fall asleep too late in the case of delayed sleep-wake phase disorder, the idea would be to expose yourself to bright light therapy early in the morning, and that would hopefully help bring your sleep up. If you fall asleep too early and too earlier than what you would want, then the idea would be to expose yourself to bright light therapy in the evening hours. All right. So all in all, the key points that I think are important to take away from this is sleep disturbance is very common in older age. The cause is often from various different reasons and often related to comorbid medical, psychiatric, and environmental factors. And we care so much about it because it can lead to many poor health outcomes, like you saw from that exhaustive slide at the beginning. And then insomnia, that's a specific sleep disorder, but its symptoms you can often see in other sleep disorders that are associated with aging. So we talked about obstructive sleep apnea, restless leg syndrome, REM sleep behavior disorder, circadian rhythm disorder. And then we spent most of our time talking about how cognitive behavioral therapy for insomnia is first-line treatment versus just going to medications. These are all of my references, and then if you'd like, you can put in some questions into the Q&A box.
Thank you so much. That was very informative. We do have a few questions.
Sure. Let's pull that up
Okay,
here.
so the first question is from an anonymous attendee, and she is asking about sleep issues related to menopause. Can you speak to that a little bit and anything you know about that particular topic?
Yeah, so that's actually a really good question. I didn't actually specifically read up on that when I was preparing for this presentation, so I apologize. But I would say just from my experience in healthcare and having patients who are going through menopause and sleep disturbance, I would say that, like a lot of individuals who have medical conditions that lead to insomnia, it's a lot of it has to do with the symptoms themselves. So, I would say having hot flashes would keep you up at night. Um, you know, a lot of times mood disorders can come with menopause, and we know that depression, anxiety can very much affect how we sleep. Um, I would want to say that how our hormones are changing during menopause can also affect sleep, but I don't want to make a definitive statement on that. I would have to read more into it.
Thank you.
Mhm.
Next, we have Greta, who is asking about using a Kindle. So her question is that a Kindle reading at night avoids light which might wake a spouse. Is Kindle light adjusted for the kind of light we are to avoid?
Yeah. So I want to say that it is, and by mere fact that I think it avoids blue light therapy or blue light, which is the light that's stimulating to the brain. Um, you would have to read, the manufacturer's label, and they should mention what kind of light is used in Kindles, but I would say that it's I think my belief is that I think that they avoid blue light, which is the light you want to avoid. I would read into it though. You could probably easily Google that or read the label on the Kindle that you've purchased.
Right. Okay. Next, we have the question, what is a normal number of times to get up to urinate for older people during the night?
Mm,
Yeah, that's
that's a
probably
good
a difficult
question.
one because I'm sure normal varies a lot.
Yeah, normal does vary a lot. You know, I don't know if there's actually been any studies on that to definitively say like a hard cutoff. This is abnormal. This is normal. Um, and I also think it depends on the individual. I've met patients who say, "Oh, I wake up 4 times and I can go right back to bed. It doesn't bother me." I've met other individuals who say, "I wake up and it really bothers me. It disrupts my sleep because I can't fall back asleep." So I actually don't have a good answer for that. I think if it's something that you're concerned about and it's not normal for you, um, I would bring it up with your PCP. And there are different reasons for why you wake up and pee frequently at night. For men, it can be a prostate issue. For women, we can sometimes have overactive bladder. It could be a sign of poorly controlled diabetes. So there's many different reasons why you're waking up and urinating at night. And um, that would be something I would bring up with your primary.
Thank you. So someone is asking if you can switch to the reference slide so that way they can see that information.
Sure, yeah.
Perfect. So next question, what about going to sleep okay, but being awake for hours in the middle of the night?
So, that is a common pattern of sleep. You One thing that I've seen commonly associated with that pattern is oftentimes related to like stress and um, more of like a psychiatric component. So oftentimes people who have, depression, anxiety, they often have that sort of pattern of sleep. Um, that's what I'm familiar with.
Thank you. What about light therapy? And are there over-the-counter items to provide that?
Yeah, so there is. I know off the top of my head that there's something called the there's like light boxes that you can purchase that are meant for, trying to retrain your sleep schedule. I think one thing that I'm thinking of is the Happy Lamp that can be used for like bright light therapy. It's commonly used for individuals who um, have, you know, like a mood disorder, typically in the gray Michigan weather over the colder months, they can use that. But there's definitely items out there. There's a market out there for bright light therapy, and it's usually targeted for improving mood, but also retraining sleep.
I have used one before and I do find it helpful.
Yeah,
As
yeah,
we mentioned, the very gray Michigan winters,
yeah.
for the most part, it's helpful to get some vitamin D for sure. Okay.
Yeah, and it's hard to, I often find that my sleep is disturbed over the colder months, the grayer months, because I think I'm just not getting the right natural light. So I've used those lamps too, and they are helpful.
All right. What about medical marijuana? Is that effective for sleep?
So again, um, I I don't think there's any strong studies that support that it is. A lot of, like I said, with a lot of supplements, botanicals, things that are historically off label, such as marijuana. It's more of a, patient report. Um, it's more evidence based off patient report and benefit. So again, I would have to read more into the literature, but I think I would have, after reviewing for this presentation, I think I would have come over um, that had it been like definitively helpful, and I didn't. So my I would say that there's likely no strong study that shows that there is benefit, but again, for some individuals, they may find it helpful. And I know that's something that in the medical field, because it's becoming more legal to use, that there are probably going to be more forthcoming studies that look into that further.
All right. So someone was asking if you could describe what comorbid means.
Yep. So that means, um, another like, so when I say comorbid condition, I say like someone who has insomnia with a comorbid condition. That means like they, in addition to insomnia, they have like heart failure, for example, or they have hypertension. It just means like in addition to, or at the same time.
Great, thank you. Next
Mhm.
question, what is PSG?
So that stands for polysomnogram, or you might hear the term polysomnography. So that's the sleep study that you require a referral for if, for example, there's suspicion that you may have obstructive sleep apnea or um, REM behavior sleep disorder, and um, you typically go to a sleep center and they again hook you up to multiple different leads and monitor things like your heart rate, your respiratory rate, your leg movement, eye movement, blood oxygen levels. So it's a sleep study essentially.
All right. So next question, why exercise without sunglasses and in the late afternoon?
So um, without sunglasses, it gets at the idea of, like light therapy, being outside, being exposed to natural bright light, can help retrain our body to sleep at the appropriate time. And then why we try to avoid exercise in the like right before bed is that it can be stimulating for the body. You have endorphins going, you're more awake, so that can make it harder to fall asleep.
All right. And this person also said that U of M has a CBTI class.
Oh, great. Yeah.
I can look into that in the background, or maybe we can share that when we
Yeah,
send an email out.
let me go to this slide because I believe when I was looking at sorry, let me go back here. When I was specifically looking under the Society of Behavioral Sleep Medicine, on that website, there's actually a link to um, practitioners in your area that are trained in CBTI, and there was one individual that I saw through the psychiatry department who was specifically trained in this. But then looking at the American Board of Sleep Medicine website, there were multiple locations in the Ann Arbor area where it was like a sleep center. And it didn't specifically say that there was someone trained in CBTI, but just something to explore because there likely is.
And I just put in the chat, I just found some information from U of M Health, online resources, cognitive behavioral therapy for insomnia. And there
Okay.
are quite a few links there, as well as QR codes if people are interested. So we can, when we send the follow-up information for this webinar, we can include that as well.
That would be awesome. Thank you for looking into that.
No problem. And next we have, is the Apple Watch sleep information actually useful?
Um, so I've heard different things on that. I again I I've seen in the literature review that I did for presenting for this presentation, I saw that there's kind of a mixed report in that it can be helpful, but at least compared to going in for an official sleep study with a polysomnogram, it sounds like it's probably it sounds like it's likely inferior to that. So while it's not perfect, I think there is some place for it to be helpful if really that's like um your option, your one of you're limited in your options and how you can really evaluate your own sleep.
Wonderful. Thank you. So it looks like those are all the questions. Oh, I think we may have gotten one more. Let's see. Is the Oura watch helpful? Spelled O-U-R-A.
I've actually never heard of that. I don't know. I've never heard of that watch. So, is that something that's new or?
I'm not familiar with that one.
Yeah.
Or the Oura, it's the Oura Ring, it's called.
Okay. Yeah, I
Oh,
actually haven't heard of that. I'm not sure. So, yeah, apologies.
okay. So next question. So this individual had some minor surgery on their tongue. They said they had a large tongue with a possible interruption of airflow that led
Okay.
to snoring.
Hmm.
And so the question is, have you heard about the connection of large tongues interrupting sleep? If so, how much of a problem can that be?
Yeah, so one of the things that as far as like sleep related breathing disorders, you know, commonly like for obstructive sleep apnea, you in the literature and how you study it in medical school, you think of someone who is larger in weight, has a large neck circumference, but um, also too, individuals who have like essentially abnormal, any sort of abnormal architecture in their mouth and oral pharynx. So the back part of their mouth that can interrupt or obstruct airflow. Um, you kind of treat them similarly. And I'm not an expert in, otolaryngology, which is who they would likely be seeing as for the specialists, but how our nasal septum is shaped, how the anatomy in our back part of our throat and mouth, anything that can really obstruct airflow kind of falls under the category of obstructive sleep apnea.
Wonderful. So it looks like those are all of our questions. So thank you so much for presenting for us. I found it was very informative, and I hope that others did as well. So as a reminder, this information will be sent out to you in a week or two once we have the recording ready.
Great.
Let's see, there may have been one more. Someone said thank you. So thank you, everybody. I hope that you have a wonderful day, and thanks for participating.
All right, thanks for having me.
Bye.